Dr. Ed Davis is a podiatrist with over 25 years of experience treating foot and ankle problems. He believes that these problems are most effectively treated when the diagnosis and treatment is focused on the cause of the problem as opposed to treating symptoms. He utilizes advanced diagnostic techniques and minimally invasive procedures and practices the concept of keeping people on their feet as much as possible. As a result, there is minimal time lost and disability. His patients recover faster from foot problems, and they are less likely to have those problems recur. Dr. Davis received a Bachelor of Science degree in biology from Rutgers College. He received his podiatric medical degree from Temple University School of Podiatric Medicine, and he brings 25 years of clinical experience in biomechanics and foot surgery. Dr. Davis is a former surgical instructor at 2 podiatric residency training programs in foot and ankle surgery. He has achieved board certification in foot surgery by the American Board of Podiatric Surgery. And Dr. Davis was an early pioneer in the use of ESWT, or extracorporeal shockwave therapy for intractable plantar fasciitis, and brings 10 years of experience in that field. Most importantly, Dr. Davis believes that the best patient is the one who is well informed and is actively involved in their treatment plan.
So, welcome, Dr. Ed. Thank you so much for joining me.
Thank you.
And I wanted to start off by asking, how did you come about doing this procedure? And can you tell me the procedures that you do?
Well, hallux rigidus is a very common thing we encounter in podiatry. And one of the cornerstones of podiatry traditionally is biomechanics, joint function of the foot and ankle and how it affects the rest of the body. So it was always emphasized in traditional podiatry, and with the focus on biomechanics, is to preserve joint function and to preserve normal walking. So implant arthroplasty, and that's the name is implant, just means we're using something that we're going to put in the joint. Arthroplasty simply means operating on a joint, has been around for a long time. But it's not necessarily an easy thing to accomplish. And every patient is going to be a little different. Every case is going to be a little different. I started using the Primus, which was invented by Dr. Bruce Lawrence in San Diego, probably in the late 80s.
Wow.
So it's been around in some form for a long time, but it's been improved through the years. Little background, there wasn't really a good implant for the big toe joint until the 70s. There were thumb implants made out of a silicone polymer called Celastic. And Dr. Lawrence had a very long, prolific career in San Diego, probably practiced for over 40 years, actually used some thumb implants back in the late 60s. And noticing that they had the right idea, but it wasn't rugged enough for the foot, he was trying to get someone to produce the implant. Unfortunately, he could not get any interest, so he started his own company called Futura Biomedical, and he actually produced it themselves. I mean, that was a time that certainly was maybe a little easier for an individual to enter the market. Now it's a much longer process with FDA approval and so on. The interesting thing is, and what was very unique about Dr. Lawrence, and I really consider him a genius because he really understood biomechanics. And subsequently, a lot of people try to come up with other implants, and a number of them didn't have a great track record because they were not biomechanically correct.
So what makes this joint biomechanically correct in your opinion?
So first thing, you have to look at the joint. It looks like a ball and socket. The hip is a ball and socket. Mm-hmm. So the joint does two things. It bends, it acts like a hinge, but it also glides. It gives you the bit of push off and stability and push off. So that what happens is people look at it and say, well, this is a ball and socket, and when it goes bad, let's put a new ball and socket in, just like we do with a hip. Unfortunately, that doesn't work in the long term because the forces are far different. The forces don't just go through the toe joint, but there's force that comes up from the floor. And anytime you put a ball in there, that ball over time tends to start to lift up. It's called dorsiflex or lift up. And what happens is the joint starts to jam and lose range of motion. And the problem is if you have to take that out, you have a big gap and then you have a challenge as to what to do next. Sure. Now, the fact of the matter is you actually have a ball, but it's misshapen. You have a socket, although it's misshapen and damaged. But we can recreate the normal shape of that. That's a fairly simple proposition to make that ball perfectly spherical again and to make that socket concave again. And the only thing that's really missing at that point is the cartilage.
Right.
So we need a replacement for the cartilage.
Okay, so this is more of a cartilage replacement. Would that be accurate?
That's the best way to think of it.
Excellent. So let me ask you another question. When people get a chelectomy, is that just the reshaving of the ball and the socket?
That is correct. And and I think there's one thing that is very fundamental to looking at hallux rigidus. And there's 4 stages of hallux rigidus that are recognized in the literature, stage 1 through 4. And a lot of it, you have to match the correct procedure, the correct stage. So stage 1 is just starting out. In podiatry, they used to call it hallux limitus or functional hallux rigidus. And that very much responds to changes in biomechanics and therapy. Stage 2, you're starting to grow bone over the joint that's blocking it, but the cartilage is adequate. So when you shave that extra bone off, now it moves. But the important thing is if we don't have adequate cartilage to support that motion, then it's going to fail or it becomes more painful because we're asking the joint to move more when there's inadequate cartilage.
Well, and I would also say inadequate biomechanics because, at that point, as you mentioned, it's a biomechanical problem. So
Right.
biomechanics, if they're never corrected, then the problem is just going to become worse regardless of what procedure you do. And so that's why it's really important to address that. So if I'm understanding correctly, then this is just a cartilage implant. So cartilage, again, cushions, right? Cushions and protects the bone so that it can glide and move in all planes, right?
Exactly.
Yeah. So tell me, is that what other types of, and I'll again kind of call them replacements, are they all cartilage replacements and which ones are and which ones aren't?
Most of them are not.
Okay.
So a lot of them are balls and sockets or they're partial. There's what are called total implants where you're addressing both sides of the joint or hemi where you adjust one side of the joint.
Right.
So there are balls, there are sockets, there are balls and sockets. And that's really the majority of implants. Yeah. And those have a tendency that they don't have a great long-term track record because again, they're going to come loose and move and not going to stay in place because the force from the ground is pushing up even a fraction of a millimeter every year, and then they start to lock up. Sure. And then when you take them out, you have a lot of work to do. And so the problem is when people have critiques of implants, they're looking at the entire universe of implants, and you can't really do that because they're very different. So, so there were back in the 70s and 80s, there were hemi-celastic implants. Those were made by Dow Corning, and Dow Corning has some legal issues because of the breast implants. And silicone got a little bit of a bad name at that time. And it was a little bit of an unfair thing because there's a huge difference between liquid silicone and one that's solid. If you look at silicone, for example, if you ever took a piece of silicone or you ever caulked your bathtub with Dow Corning silicone caulking, it's very rubbery. It feels like cartilage. This is a medical grade one, and we can never say never, but for the most part, it's very inert. The body accepts it very well, and it causes very few issues.
Excellent. So let's talk about issues. So, what are, have there been any legalities that you know of as a result of the silicone? So obviously, I think you would have to test for allergies. Would that be correct?
You don't normally test for allergies to silicone because it's inert. And I've never heard of an allergic reaction to it. The only type of reaction you can get in theory is if that implant's degraded and little pieces of silicone broke off, the body will sometimes create a lot of scar tissue and inflammation in the area. But it's not an allergic reaction. It's really a foreign body reaction. And a foreign body reaction is something the body can mount against anything that it feels is not natural. It's, for example, the metal titanium, is rarely tested for an allergies just because the body recognizes it as self, very, very unique in that sense. Other things like cobalt, nickel, whole different story.
Sure. And let me ask you another question about the silicon. How long have the silicon implants been around? Were they the ones you referenced back since the 70s?
Correct. Late 70s, the Primus came out, and that was the Primus Generation 1. We're now in Generation 3. And then we have a very similar, I guess you could call it a copycat, called a reference toe, which is made by another company.
Okay.
But it's very similar. They may not like me calling it a copycat, but it's very, very similar. And Bruce Lawrence was their consultant back in 2013.
Right. So can you also tell us a little bit about the other types of implants? And you also mentioned stages. So at what stage is somebody a candidate for implantation?
Generally stage 3. In stage 3, you would consider a hemi implant, where you're just adding a surface to one or the other side of the joint. The problem with most of the implants for stage 3, and that they're hemi, right now there are no celastic implants on the market, so they're all metal. And the dilemma you run into is if you have wear on both sides of the joint and you replace one side with metal, well, metal against soft tissue, metal against cartilage, that wears off the other side. So they're very problematic. There is one that came out a number of years ago called Cartiva with a lot of fanfare. And that is a soft material. Basically, it's a type of contact lens material that's used to resurface the metatarsal side. So that has some use in stage 3, and we use it in a limited fashion.
Okay. So when you're saying the celastic implant, so it replaces the cartilage on both the ball and the socket.
The Primus, correct.
Yes. I'm sorry. Yes, I misspoke.
That's truly for stage. That's more for stage 4. So late stage 3, stage 4. And that's where a number of surgeons like to fuse the big toe joint, which, again, if you fuse a big toe joint, you don't have a big toe joint. It's just one solid bone when the fusion is done.
Yeah. No, I'm highly against that just because of the responsibility of the big toe. I personally think it's one of the most important structures in the human body. And
very much.
I know that correcting my big toe has saved me from knee surgery, and I've even addressed the big toe for individuals with hip problems that have been really, really successful as well. So it's not just, for those people who are considering fusion, I know I would, and I'm sure you would too, recommend doing everything to avoid that.
Correct. It's been hypothesized that the human body is a perpetual motion machine, that essentially we have the ability to walk for very long periods of time with not a tremendous amount of energy expenditure if there are no mechanical blocks to motion, mechanical deficits. And so any lack of ankle dorsiflexion or backward range of motion, that's an issue. Issues at the knee, hip, sacroiliac joint, big toe joint. But if the big toe joint is locked up, it works its way up the chain to the ankle. You're changing, and there are people who can adapt to fusions fairly well. But again, we have a tendency to look at things in a very short-term span. If you look at all the papers that advocate for fusion, they talk about the success rate. The success rate's based on the big toe joint not hurting. Well, if you do not have a big toe joint, so if you fuse a joint, you do not have a big toe joint.
Right.
And when you fuse that big toe joint, it in theory can't hurt. And so there's all these papers that say fusion works. The problem is they don't go out more than 5 years, number one. Number two, they do not take into account all the other problems that occur. If you're walking on the side of your foot, well, now you sprain your ankle easier. You stress fractures. You stress the outer structures of the knee, the iliotibial band, which is structure on the side of your leg and hip. One thing, if you look at the position of someone as they push up, as they mount that big toe, the leg is internally rotated. You're rotated toward the big toe. So if you look at the hip joint is now in the posterior or back of the hip joint. That's the deepest part. If I try to push off on the side of my foot, well, now the ball and socket is in a different position, and it's a weaker position with a lot more motion, so potentially more hip pain, sacroiliac pain. And again, unfortunately, the studies being done just don't take all that into account because it's a very narrow focus. Painful joint, we fuse it, joint gone, no pain. Very simple and not very and not really very comprehensive.
Not at all. Not at all. I agree 100%. And just going back to walking, I believe humans can walk. I know they can run further continuously than any other animal. So I would probably translate that into walking as well when you're biomechanically sound. Correct. When you're not, that's when things go awry. That's why I'm such a proponent of alignment and adequate motion for sure. And the other thing about fusions is that if the mechanics haven't been changed, then you're going to have all these compensations already that you've been accruing for a number of years as this has degenerated. And it's just like weight gain. You know, if you woke up one morning and you were 40 pounds heavier, you would feel it. But when it happens over time, you don't notice it until other things start deteriorating. And, you know, you bring up an excellent point. So if somebody has had a fusion, there's a good chance that they might not notice a hip or a knee or back problem until years later. And I have a saying that we get pain when we run out of compensations. So,
very true. Very true.
Yeah. So excellent. So if somebody is going to have a negative side effect, what would it be?
I think that the negative side effects that I would have encountered would come from technique issues and rehabilitation issues, and number three, not controlling the underlying mechanics.
Sure.
The rule of thumb is, if you look at every implant out there, the minute you put it in on that table, that big toe joint is moving. The question is what's going to happen afterwards. Now, sometimes, again, the ball and sockets, they're going to lose position over time. And so there is a design issue right there. But if we don't correct the underlying biomechanics that cause hallux limitus or hallux rigidus,
yes,
and if we don't do proper rehab, then we're not going to get the results we want. Absolutely. So I tell people that this is part of a comprehensive treatment plan. We've got to get the joint moving. We have to get the biomechanics corrected. We have to get proper rehab and get you walking properly. So this is all part of the process.
Good. Yeah. So it's probably, no different than the complications that would happen with any kind of surgery, right. Any kind of minimally invasive elective surgery.
Correct.
Yeah. Okay. And how soon can people get back to activities? And when is it safe? That's the important thing too. And what are the guideposts to safety?
So this is very much the anti-fusion in terms of rehab. So if you fuse a joint, for example, you're putting screws across, you're putting a plate across, that person has to be off their foot. You cannot move it, otherwise the fusion won't heal. And that can be a 10 to 12 week process. Mm-hmm. With an implant, the sooner you move it, the better it is. Mm-hmm. So we're doing that. We do it under general or even sometimes local with sedation. I just did one. Some people prefer that. Patient goes into a surgical shoe, and a surgical shoe is a stiff shoe. So we have them wear that for a week and a half. Then we have them come back in a week and a half, bring an old pair of running shoes you don't like anymore, something in the back of the closet. We're going to cut out the front half of the shoe because we want something flexible. So initially, it's more a matter of passive range of motion than assistive and active. So there's a continuum of increases of motion that goes on. But one of the things you got to look at with every type of surgery, the body initially heals with inflammation. So there's an inflammatory phase. The body sends in white blood cells. There's a little bit of bleeding there. And then that occurs for the first week and a half to two. As you get that second week and into the third week, the body is bringing in fibroblasts, which are cells that create scar tissue, and some scar tissue is normal, but too much scar tissue is going to limit the joint range of motion. So ideally, we'd like to get 65, 70 degrees of dorsiflexion, that's backward range of motion on the table. But we're going to, as the days and weeks go by, we start to lose some of that. So we need that passive range of motion just not to lose any of that, because anything we lose, then we have to work hard to get it back. So we want people walk. So that person's going home, putting their foot up. The next day they can walk with a surgical shoe. The next day a little bit more. Next day a little bit more. Now you're walking with something that doesn't bend very much. Between a week and a half and two, we want something that bends. We like to start that therapy by the beginning of the third week, just before the scarring phase of healing sets in.
Sure. And another question that I have, when you're saying 65 to 75 degrees of dorsiflexion of the big toe. So what's interesting to me is that when we measure dorsiflexion, it's typically in the open chain, meaning that the foot is not on the floor. However, functionally, the big toe is in the what we call closed chain, right? So that the end of the big toe is on the ground and then the foot is moving around it.
Okay.
So how do we, how wouldn't we want to try to improve it in a functional position?
Well, the thing is, what we're doing initially is just restoring that range of motion. So it's really a structural change for the most part. But the foot goes through phases of gait. And initially, the person steps, the heel contacts the floor, the leg is rotating in, and the foot, and essentially your subtalar joint, which is the joint below the ankle, is rolling in. That's called pronation. Right. Sometimes pronation is used in a negative sense, but pronation is a normal inward rolling of the foot. And that allows the foot to roll to the ground. It takes the vertical forces and translates them into a rotary force. In other words, it's a shock absorption mechanism. Allows the foot to come down, and as that foot rolls forward and you get to we move toward the big toe, the foot has to resupinate. It means that it has to then roll out a little bit. And the reason is there's a muscle or muscle groups that basically take the big toe joint and rotate it toward the floor. In other words, the foot has to arc up. And you could literally stand on the floor and put your foot down and roll toward the inside of your ankle and go into the motion of pronation. Try to lift up your big toe and you lose range of motion. If you supinatal, but you let that foot arc up, you get a greater range of motion. And it's very basic mechanics, which shouldn't be forgotten when we talk about the body, because essentially we want the joint to look like this, so we get good bending. If the joint's riding up, we get a locking and jamming to occur. So one of the things about therapy, we really have to get good first ray function. First ray means the big toe, the first metatarsal, and the structures in back of that. It has to arc up and it has to toggle. We need a toggling effect to occur. It's the best way to look at it. And if the first metatarsal is riding upward because of too much pronation, because of too much supination at the mid-tarsal joint, then we don't get that toggling effect. But even surgically, we have to look at it, because people are, again, we get into tunnel vision where you're looking at the big toe joint, and a lot of times surgically we're addressing that, but sometimes we have to go way beyond that in surgery, because if someone has a metatarsal that is riding upward, every implant is going to fail. The best implant in the world is going to fail because it's in the wrong position. So another procedure has to be done to lower that first metatarsal. It's not just about the implant. Yeah. So we can't take that simplistic view, and that's why the easiest surgery you can, the two easiest surgeries you can do, healectomy, which is just shaving off the bump, and fusing, the two easiest surgery for the surgeon. Yes. And insurance companies pay more for fusions than they do for an implant, despite the fact that implants take a lot more work. But essentially, you have the biomechanics of the joint have to be looked at, and some of it can be addressed surgically, some with therapy, and some with orthotics.
So would you say that hallux, the disease process progresses because the foot does not go into proper pronation during the stance and push-off phase of gait?
Correct, and that's when we talk about really the mid-tarsal joint has to fully pronate. I think that what the layperson has an issue. You start Googling these terms, and the information is not great because it oversimplifies it. pronation is sometimes looked at as a flat foot, and it's not. It's an inward motion.
Correct.
And pronation at the right time is very, very good.
Yeah.
It's pronation that's too much, and at the wrong time, that's not. But the mid-tarsal joint, which is the front of the foot, which you don't see a lot of talk about, that's when it has to fully pronate it, because that locks the first metatarsal on the ground.
So I'm sorry, say that again for rehab people like me. The first metatarsal?
So the first metatarsal has to be plantar flexed, in other words,
downward,
toggle, and locked under the ground. And the mid-tarsal joint, when it's fully pronated in propulsion or propulsive phase, we need that maximum pronation.
Yeah.
So if I was to give you an example, if I was going to make an orthotic for someone with hallux rigidus, and I'm just generalizing because people are different, but a lot of times we're going to have something called the first ray cutout, which is something that allows the first metatarsal to drop. We may have a forefoot valgus post that tips the foot into more pronation. We may have something called the reverse mortise extension. And it's really a pad under the lesser metatarsals that rotates that big toe up against the ground.
And would you say that the majority of people who have hallux limitus, hallux rigidus, do they usually have a foot that would have a high arch, or is it 50-50?
It's 50-50. Because, and I think people get a little bit obsessed with arch height, and it's not, because arch height is an architectural issue, and function, structure and function do go together, but it's more the function that we're really looking at. What's really going on functionally?
Interesting. Yeah, of course. And that's why gait analysis and those types of things are really important as well.
Right.
Excellent. I think we covered all of the questions. So when are people back to sport? So we talked about beginning therapy at 3 weeks. We talked about passive range of motion, to prevent scar tissue from forming. And so when can people get back to sport, or is that a PT issue?
It's a biomechanics, PT, and individual issue, but just in generalities, I'd like to see people walking as much as possible by week 5. And so one of the issues with walking, and we talked about things happening incrementally. Well, if a person has hallux rigidus, one of the things you're going to see is a shorter stride. People have to shorten their stride because they can't push off. So you really have to. One of the things we tell people as we get past the first 4 weeks, go out and walk as much as you like, the way you normally walk. Then after you walk for a half a mile, start taking the longest step you can possibly take, because you have to reprogram that person to walk properly.
Absolutely.
What happens is the longer the stride, the more you have to use that range of motion of the first MTP.
Absolutely.
Point. The more you will have to strengthen those muscles. The other thing you're going to find is that you can give people motion, but do they have the power, the muscular force and stability to support that motion? And one complication we have run into is that sometimes the implant works too well. And what that means is I've had people, after a month, wow, I can run. Well, don't do it.
No.
And so I've had people actually get stress fractures because they think, wow, this feels great, I'm going to go run. And I said, well, your issue is that you don't have the stability, you don't have your gait is still off. And if you do it, you're going to put yourself at risk. So I've seen some stress fractures just because people become exuberant because they're like, wow, it doesn't hurt, it bends.
Sure.
I'm going to go and do what I want to do.
Right. More is better. No pain, no gain.
Exactly. You really got to, reestablish your normal gait, get protective shoe gear, use an orthotic, and get that strength back.
Absolutely. Last question, again, for rehab people like myself. How soon post-surgically can people begin doing isometrics, meaning that they're not moving the joint, but they're just activating the muscles?
Really within days, if they would like to do that, because there's no consequences for doing so.
Yeah, I would think not either. And I think that's where a lot of people get it wrong. Okay, great. Anything else that I didn't cover that you would want people to know?
Well, I think it's important whenever possible, and it's not an easy task, is to find doctors who understand biomechanics. Because essentially, got to remember the The two easiest procedures you can do is a chelectomy and a fusion. And so you don't really, those are very basic skills that allow you to do that. So to restore a joint, to get it moving properly, to understand the rehab, you need a doctor who really has that knowledge base. And I wish I could just give you a list, but I really can't. I mean, I know just on a personal basis, having been around for a while, doctors who can do that. And that's another reason why I started the Facebook group, because I looked at a lot of the hallux rigidus boards, and the information I just felt needed to be better. And so I wanted one I could moderate. I could invite some other doctors on. I can invite healthcare professionals, therapists on for input, just so that we can just raise the quality. So we call it hallux rigidus science and support. I'm just trying to come up with a Facebook group just to raise the bar a little bit. So we can get into these discussions. We want people to read and educate themselves so they really understand the options. And again, sometimes it's a geographic issue. People in certain other countries, they're not giving a lot of options. But fortunately, in the United States, we have all the options if you're willing to seek it out. But I'm a strong believer that people have to educate themselves.
Absolutely.
Because, we have a wealth of information out there. I think the challenge is sometimes separating the wheat from the, the cream from the chaff, so to speak. And that's challenging. So we're trying to raise the bar on information and let people educate themselves to understand what the proper treatments are.
Yeah. And that was one of the reasons why I wanted to have you on today. So thank you so much for educating me and giving better information or more information, because knowledge is power, and to the audience. And I have some guidelines too that of questions you need to interview everybody that you work with, because regardless of your title, it's about the person, the professional, I should say, not what they do. It's about who they are and what they know and how if and how they can help you. So with that, I will thank you again, Dr. Ed. I really enjoyed this conversation and look forward to more of them.
Thank you very much. Really appreciate it.
Okay.
Thank you so much for joining us today on Step Up with DL Walker. If you enjoyed this video, go ahead and give it a like and share it with others. Be sure to add any feedback or questions in the comments box, and you can reach out directly to today's guest and myself using the contact information found in the description box below. To learn more ways to take control of your health, subscribe to this channel, visit our website, and watch more training videos. Until next time, thanks for watching.